Okay, let's talk about anatomy of the extraocular muscles. At first, we have to do, or we have to know the origins, insertion, the nerve supply, the blood supply, and the action of all of the extraocular muscles, together with some information about the differences between the extraocular muscles and the skeletal muscles elsewhere. Okay, so let's start with the origin of all the extraocular muscles. All the extraocular muscles arise from the orbital apex, like that. This is the orbital apex. So all of the extraocular muscles arise from the orbital apex, except the inferior oblique muscle, which arise from the orbital floor. Okay, so let's talk about the recti muscles. Regarding the origin of the recti muscles, they originate all from something called the annulus of Zinn. You remember this one, you remember the superior orbital fissure like that, which is traversed by the annulus of Zinn. Here you have the origin of the medial rectus, the origin of superior rectus, lateral rectus, and inferior rectus like that. Okay, this is the origin of all the recti muscles. Okay, actually there is a spine here in the lateral part, which is another origin for the lateral rectus muscle. So there is an orbital spine in the orbital bone, or in the bone of the orbital apex. This is another origin for the lateral rectus muscle. Okay, so this is regarding the origin. What about the insertion of the recti muscles? They are all inserting within the sclera or in the sclera, but they are not at the same distance from the limbus. Okay, for example, here, look at this one. Let's imagine that this is the cornea here. The medial rectus will be inserted here, which is at a distance which is nearest from the limbus, 5.5 millimeter. After that, you have the inferior rectus here, which inserts at a distance of 6.5 millimeter, and here this one, which is the lateral rectus, and finally this one, which is the superior rectus. The lateral rectus 6.9 millimeter from the limbus, and the final one, which is the superior rectus, 7.7 millimeter from the limbus. If you connect these points or these insertions with each other, you won't find a circle. You will find something called spiral. Okay, so it will be like that. This is called a spiral, not a circle, because they are not inserting at the same distances or at the same distance from the limbus. You have the nearest insertion from the limbus, the medial rectus, which is 5.5 millimeter. After that, the inferior rectus, 6.5. After that, lateral rectus, 6.9. And finally, the superior rectus, which is 7.7. So medial, inferior, lateral, superior. Okay, and this is called spiral of Taylor. This is regarding the insertion of the recti muscles. What about the origin and the insertion of the obliques? I have here the superior oblique muscle and the inferior oblique muscle. Superior oblique muscle also arise from the orbital apex like that. But here in the anterior part of the orbital, of the medial part of the orbital roof, I'll have here a structure like a sling like that, which is called the trochlea. Within this trochlea, it will shift or change the direction 180 degrees like that, in order to be directed from anterior to posterior like that. And this is the globe here. Let's imagine that this is the globe. Okay, and it will be inserted like that. Okay, this insertion is in which quadrant? Is it
superolateral?
Superior lateral and posterior. Okay, and this word posterior is very important. Why it is important? Because if you want to, if you want to move the muscle from the insertion to the origin, if you want to move or shorten the muscle from the insertion to the origin like that, this will result in elevation or depression of the globe. What do you think? Imagine that.
It's depression, I'm sorry.
Depression, yes. If you want to shorten the muscle from the insertion to the origin, this will result in depression of the globe. Yes. Okay. So the origin is the lesser ring of the sphenoid bone, which is not the common tendinous ring or the annulus of Zinn, but it is also the orbital apex. from the lesser rung of the sphenoid bone. What about the inferior oblique muscle? Here, the inferior oblique will be from anterior to posterior, but from this part, which is called the orbital floor. Okay, just lateral to the opening of the nasolacrimal duct. Okay, so this is called the inferior. This is called the inferior oblique muscle. Okay, so what do you think of the action here? If you want to shorten the muscle from the insertion to the origin like that, this will result in elevation or depression?
Depression again.
Elevation.
No elevation. Here, imagine that you are moving the muscle from posterior to anterior here like that. Okay, shorten the muscle from posterior to anterior. You will find that the globe will be shifted like that. So the globe will be elevated. That's why the oblique muscles have an action which is opposite their names. So the superior oblique will result in depression. The inferior oblique will result in elevation. Okay, this is important one. So the origin of the inferior oblique muscle is from what? It is from the orbital floor, and the insertion is within which quadrant of the globe? Anterior or posterior, inferior or superior, medial or lateral? Again, it is posterolateral inferior quadrant. Okay, posterolateral like that. This is posterolateral also, but for the superior oblique, it is posterolateral superior, and for the inferior oblique, it is posterolateral inferior. Okay. Is it easy, the origin and the insertions of the extraocular muscles?
Yes.
Okay.
Sorry, the inferior
Yes.
oblique is posterior lateral, right?
The superior oblique is posterior, lateral, and superior. Yes, this is the insertion.
Yes, okay.
Okay. Let's talk about the nerve supply, and this is very easy. All extraocular muscles are supplied by the oculomotor nerve, except for the SO4, which is superior oblique from the fourth nerve, and LR6, the lateral rectus from the trochlear nerve. Okay, and the rest of the extraocular muscles are supplied by the oculomotor nerve. What do you think of which branch of the oculomotor nerve? I have here superior division and inferior division. The superior division will supply just the superior muscle, which is what? It is superior rectus, okay? Together with the levator palpebrae superioris, because they may share the common embryological origin, okay? And the inferior part will supply which muscle? The rest of the muscles, which are the medial rectus, yes, inferior rectus and inferior oblique, and here nerve to inferior oblique is the continuation of the inferior division. So nerve to inferior oblique is the largest one because it is the continuation. Okay, so these are these are the information regarding.
Excuse me, why the inferior rectus is what you said the last word? It is continuation.
Okay. The last word is the nerve to inferior oblique muscle.
Yes.
Is a continuation of the inferior division of the third nerve. So the third nerve, imagine that the third nerve has two divisions, superior and inferior. This superior is easy. Okay, and this inferior will give branch to medial rectus, branch to inferior rectus, and the continuation here, the continuation will be the nerve to inferior oblique. So the largest one,
yes, it is the thickest one. Yeah, okay.
Also, it contains the parasympathetic fibers. Okay, so the parasympathetic fibers goes with nerve to inferior oblique like that. Okay, this is regarding the nerve supply. Another issue about the nerve supply, which is from which part of the muscle the nerve traverse or the nerve will be. Okay, so regarding the superior rectus muscle, we imagine that the nerve will be inferior to the muscle like that. So the nerve will supply the muscle from inferior. Regarding the inferior rectus, the nerve will supply from superior. Regarding again the inferior oblique, the nerve will supply from superior like that. Regarding the medial rectus here, the nerve will supply from the lateral side. No, this is called the medial rectus, so this is the lateral part. Okay.
Oh yes.
And the reverse is true for the lateral rectus. The nerve will supply from the medial side.
Medial side.
The exception for all of these is something which is the superior oblique muscle. Okay, regarding the superior oblique muscle, here the nerve will supply the muscle from above. So this is the exception of all the rule. So the rule is that the nerve will supply the muscle from the opposite side to its name. So the medial will be supplied from its lateral surface. The lateral will be supplied from the medial surface and so on, except for the superior oblique muscle. You can write down this because this is not written in my notes, and this was asked before in a previous exam. So I want you to add this. The nerves are supplying muscles from a surface which is opposite, which is always opposite its name. So the medial rectus, for example, the medial rectus will be supplied by a nerve from its lateral surface, except for the superior oblique, which will be supplied by a nerve, okay, supplying the muscle from its superior surface again.
Okay.
Okay. Is it easy up till now?
Yeah, it is.
Yeah.
Yeah.
Yes.
Okay, so let's talk about the action of the extraocular muscles, and this is the tough one here in this session. What about the action of the extraocular muscles? Regarding the horizontal muscles, they are always parallel to the optical axis like that. So I have here the medial rectus, for example, and here the lateral rectus, for example. The medial rectus will result in adduction of the globe or inward movement like that, and lateral rectus will result in abduction of the globe like that. Okay, this is very easy: abduction and adduction, or adduction and abduction. So I have here just one action for the horizontal muscles. Why do I have just one action? Because of what? Because they are always parallel to the optical axis. They don't have any angle with the optical axis. Okay. The problem is in the vertical muscles, and let's start with the recti muscles. Okay, I have here superior rectus and inferior rectus. Both of them, either the superior or the inferior, will create an angle or have an angle with the optical axis like that. The optical axis is the midline axis, which is lying in the middle, just in the middle of the globe like that. Okay, I have here the muscle. I'll make it in black. Let's imagine that this is the nasal side and this is the temporal side, for example. Okay, the muscle will be like that. This is the axis of the muscle. So the muscle will create an angle with the optical axis, which is 23, but to the lateral side. In order to make this muscle, like the superior rectus or inferior rectus, elevate or depress the globe, I have to do what? I have to be parallel to the optical axis. So I'll be parallel by doing what? Here, let's erase the optical axis and move the globe laterally like that. Okay, if I move the globe laterally here like that, I'll make the optical axis what? I'll make the optical axis parallel to the axis of the muscle. That's why in this position, this muscle purely will result in what? Will result in elevation or depression, either the superior rectus or the inferior rectus. So the superior rectus will create elevation of the globe here in this position. The inferior rectus in this position again will create depression of the globe. Okay, this is the first action. I have another possibility here. I imagine that I have here the optical axis here again in its position, and the patient is looking in the primary position. The other possibility, if the patient adducts like that, if the patient adducts here like that, this will create the optical axis here, and this will result in having optical axis perpendicular to the axis of the muscle. So the axis of the muscle here won't be parallel; it will be perpendicular. So when you contract this muscle, when you shorten the muscle from insertion to origin, this will result in just torsional movement. The patient will have torsional movement, so it will result in intorsion or extorsion. Do you agree with me in that? Can you imagine this one? I think I have here Yes, I have here something like that. Okay, look at this muscle here, which is the superior rectus muscle, for example. I'll imagine that this is the superior rectus muscle. If the patient is looking here like that, the optical axis, which is pink in color, will be parallel to the blue one, which is the axis of the muscle. If they are parallel, then the globe will be elevated. Okay. And imagine that the globe will be adducted like that. If the globe is adducted, the optical axis will be perpendicular.
Perpendicular. Okay.
Yes. And this will result in what? This will result in just torsional movement, intorsion or extorsion.
Not elevation.
What?
Not elevation.
Okay. What do you mean? No, no. If it is perpendicular, this will result
Only
in
in this case
intorsion.
we have an elevation. Yes.
Torsional normal, yeah.
Excuse me.
Okay, okay. Let me repeat this. Okay, let me repeat this. You have three possibilities, okay, for any vertical muscle. If the muscle is parallel to, if the axis of the muscle is parallel to the optical axis, like in this one, here, this is the axis of the muscle and this is the optical axis. They are parallel. So this will result in elevation or depression. I think this is easy, okay?
Yes.
If we are parallel. But here, the other possibility, which
but
is...
it does not happen when we are looking straight forward, or when we look straight forward. Yes, when the eyes are fixating forward.
Okay,
in this case, axis
this
is not parallel. Yes.
Okay. Yes. In the primary position, when we are looking forward, it is not parallel to the optical axis, and this is the third possibility. Okay. So I have the first possibility, which is parallel to the optical axis. We have also the second possibility here, the eyes looking adducting like that. And this is the optical axis. Where is the axis of the muscle? Here. This is the axis of the muscle. So here I'm perpendicular to the optical axis. So contraction of the muscle won't result in elevation or depression. Will just intort or extort the eye. Okay. This will result in intorsion. Yes, torsional movement, intorsion or extorsion.
Okay.
Okay. Is it easy? Here, if you don't, if you are not parallel, neither parallel nor perpendicular, like what you said in the primary position. Actually, in the primary position, you don't have any. Sorry, you don't have any specific action. Your action will be complex, and this is the state or the status of most of our movement. Most of our movement are complex, because here, if you want to be parallel, you have to do abduction, which is abduction for just 23 degrees in order to be parallel to the optical axis. And if you want to be perpendicular, you have to do adduction, which is adduction by about 67 degrees. Actually, these degrees are not sharply achieved in our real life. Okay, so most of our actions are complex action. So, for example, the superior rectus muscle will result in elevation or intorsion, or both of them, and mostly it will result in both of them. Okay. Do you understand this one?
Yeah.
May I repeat this one?
So
you want me to repeat this one? Okay, so here I'll repeat this. I have here the optical axis, which is here in the primary position. I have here the axis of the muscle, which is in green here. The axis of the muscle will have an angle. I'm talking about the recti muscles, either the superior rectus or the inferior rectus. Here, it creates with the angle 23 degrees, or creates with, the optical axis 23 degrees. So if you want to be parallel, you have to move here in abduction like 23 degrees. Okay, abduction by 23 degrees in order to be parallel with the optical axis. And if you want to be perpendicular like that, you have to move like 67 degrees. Which is easier for me or for a muscle to move 23 degrees or 67 degrees? Which is easier?
23 degrees. 23, yes.
Yes, 23 degrees. And this 23 degrees will result in elevation or depression. So this is the primary action. Why it is the primary action? Because you have to move a shorter direction or a shorter angle in order to or a narrower angle in order to create this action. So the action which is near the visual axis or nearer to the primary position, this is called the primary action. Okay. So here the primary action will be elevation or depression, and elevation or depression will be purely achieved by abduction by 23 degrees. What about the secondary action here? Because it is wider than, or because it is longer than 23 degrees, it is 67 degrees. So the secondary action here will be intorsion or extorsion. Okay. Actually, the superior rectus will result in intorsion, the inferior rectus will result in extorsion. And if you want to make it purely achieved, you have to move the muscle like 67 degrees. You know the torsional movement? You can imagine the torsional movement. Here, if you want to imagine the torsional movement, imagine that you have a patient like that and you make a mark on its limbus or on his limbus like that on the 6 o'clock degree, okay, on the 6 o'clock, and ask this person to rotate his head either to his right shoulder or to his left shoulder. Okay, you will find that this will move. The globe is not medially or laterally rotated. The globe is not elevated or depressed, but this mark will move. This is called torsional movement. Okay, either intorsion to inside or extorsion to outside. And you can create this, you can notice this by looking at the mirror and watching your eyes while you are doing head tilt to the right shoulder and the reverse head tilt to the left shoulder. You will find that your globe is rotating, but actually you don't have either medial rotation or lateral rotation or elevation or depression. You have just rotation of the globe. Okay, just intorsion or extorsion. Okay, this is the torsional movement, and this can be achieved by making the muscle perpendicular to the optical axis. What about the oblique muscles? Here, the oblique muscles, I'll imagine also that I have the globe here, and here this is the nasal side. Again, this is the temporal side. This is the optical axis. These oblique muscles are creating an angle, which is what here. This angle is 51 degrees with the optical axis, like that, but to the nasal side. So in order to make elevation or depression, I have to make adduction with medial rotation by 51 degrees. If I want to have torsion or extorsion, I must be perpendicular to the optical axis. So I have to do abduction by 39 degrees, which is easier for me, to be parallel or to be perpendicular here in this case.
39 degrees.
39 degrees, which is perpendicular. Okay, 39 degrees, because here I must be perpendicular to, if I move 39 degrees to the abduction, I'll be perpendicular to the axis of the muscle. Okay, so the primary action here will be what?
Abduction.
The primary action will be torsion. Okay, intorsion or extorsion. Because of what, doctor? Because I'm right now I'm perpendicular to the optical axis. I'll make illustration of this. Actually, there is someone here. Look at this one. This is the blue one is the axis of the muscle, and the pink one is the optical axis. In order to be parallel to result in elevation or depression, I have to move all this movement. Okay, so I have to do adduction. Adduction of what? Adduction of 51 degrees here, like that.
Okay, yeah.
Okay, in order to be perpendicular, I have to make this optical axis, which is pink. I'll make the globe here like that, and the optical axis will be here. So I have to be perpendicular by 39 degrees. Okay, so I'll make abduction, which is outward rotation. Yes, by 39 degrees. This will result in what? This will result in torsional movement, just torsional movement. Okay. Imagine that you shorten this muscle here, shorten this muscle, which is the superior oblique one. If you want to shorten this one, you will result in just torsion of the globe. You won't result in elevation or depression.
Okay, I guess. So you, okay.
Okay. So here, the primary action of the obliques, we are talking right now about the obliques, which create an angle which is 51 with the optical axis. The primary action is what? Is the nearer one to the optical axis, or the primary position, which is what? Intorsion for the superior oblique and extorsion for the inferior oblique. What about the secondary action? It will be elevation or depression. Okay, elevation by inferior oblique, depression by superior oblique. And here in the primary position, you have to do abduction by about 39 degrees. In the secondary action, which is elevation or depression, you have to do adduction of what? 51 degrees. Okay.
Okay.
This is regarding the primary and the secondary action for all of these extraocular muscles or vertical extraocular muscles, vertical muscles. Is it easy or some?
No.
No, it's not easy.
Okay, it is not easy or easy?
No,
No.
it is not easy.
Not easy.
Not easy.
Yes.
But I think it is.
We will
right
work
now,
about this topic.
excuse me.
Yes.
We will work about this topic hard.
No. I want you to understand this before this session. Okay, before this session.
Oh, sorry. Can you please repeat the last thing you said, like about?
Or maybe we can watch some videos also. Maybe it will be a little bit easier to imagine. Some are there any kind of videos to show this?
Okay. I'll show you something. I think it is present here, on my iPad. It is not a video, but it is
Animation, maybe.
No. It is my strabismus PowerPoint. Okay. Strabismus division.
Well, I hate this part in ophthalmology.
Strabismus is
Yes.
very
Me
good.
too.
I hate.
I
Very
like
good. Yes.
I like
hate.
strabismus mostly.
No, this
Okay.
is because I don't really understand much.
Okay. I'll make you understand this one.
Thanks.
Strabismus introduction. This one. Okay, here. Look at this one. Yes. Regarding the recti muscles, okay, imagine that this is the superior rectus muscle, for example.
Yeah.
Okay, if you are rotating the globe here, the optical axis, as you see, is parallel to the axis of the muscle, like that. Okay, and the cornea is looking in this direction. Okay. So here, what is the action that you suspect? Here, the superior rectus, which is attached to the superior part of the sclera, will result in elevation of the globe. Do you understand this? This is easy, I think. Okay, look at this one. If the globe is rotated here, like that, okay, the globe is rotated to the median. So the globe is abducted by 67 degrees. What do you think of this muscle? This muscle is perpendicular to the optical axis, like that. Okay, if you want to shorten this muscle, this won't result in elevation or depression. This muscle, yes, again, it is attached to the superior part of the globe. But if you want to shorten this muscle, the globe will be just rotated. Okay, it will be intorted in this example. I think this is easier one.
Yes, this is easier one.
easier.
Yes, it's difficult with the oblique muscles.
Yes. Okay. The oblique muscles, it is the same here. Yes, these are the oblique muscles. Here, this is in the primary position, so forget about this. Look at this one. Here, the globe is looking medially, so the globe is adducted here in this example here. You notice that the cornea is looking at the same direction with the axis of the muscle. So the optical axis is parallel to the axis of the muscle. And imagine that this muscle again is inserted into the superior part of the superior part or the inferior part of the globe. If you want to shorten this muscle, this will result in elevation or depression. Okay. But look at this one here. The globe is looking here and the muscle is here. Okay, so the globe is right now is perpendicular to, sorry, the optical axis is perpendicular to the axis of the muscle. If you want to shorten this muscle, can you shorten this one here or here? Yes, here, like that. You will result in just torsional movement. The globe will be again intorted or extorted. I think this is easier.
Yes, it is clear. So when there is a perpendicular position, we have extorsion or intorsion. When there is a parallel, we have an elevation or depression.
Yes, and you can imagine this if you have a ball. Can you have a ball right now? If you have a ball and you are perpendicular to the direction of this ball, imagine, or you can draw on a ball, you can draw the side of the cornea, okay? You can imagine that you have a side of the cornea. If you are attaching to the superior part of the ball, like that, this is a ball here, okay? Here in this one. And I'll imagine that I have a cornea here. Sorry, I'll imagine that I have a cornea here. So here, the muscle, which is your fingers or your hand, is perpendicular to the direction of the cornea. So when you shorten, yes, this will result in torsional movement. And here, imagine that the direction will be here. You are directing the cornea here. This means that you are parallel to the muscle, for example. Okay, like that, you are parallel to the muscle. So when you contract the muscle, this will result in elevation or depression. Okay, so I think this is right now it is easier.
Yeah.
Okay, so this is the primary action for the recti muscles, the oblique muscles. Let's mention just 5 rules in order to memorize all of these. Rule number 1. Okay, rule number 1, which is regarding the recti muscles. What is the primary action for the recti muscles? Elevation or depression. What is the secondary action for the recti muscles? Intorsion or extorsion. This is rule number 1. Rule number 2 regarding obliques, it is the reverse. Okay, for the primary position, for the primary action,
You mean superior rectus and inferior, right? In first meaning.
Yes, superior rectus and inferior.
Yeah, okay.
Elevation by superior rectus, depression by inferior rectus.
Yeah.
Okay, for the obliques, the primary action will be intorsion.
Elevate.
No, intorsion and extorsion, because it is nearer to the primary position. This is nearer to the primary position. Because if you want to do this, you have to do just abduction by 39 degrees, like that. Okay? And what is the secondary action? It will be elevation or depression. Because if you want to have this action, you have to abduct the eye by 51 degrees. Okay, rule number 3, all superiors are intorters. So the superior rectus, superior oblique will result in intorsion. Okay, and the reverse, all inferiors are extorters. Okay, rule number 4, which is very important, which muscle is the main elevator and the main depressor in which position? Okay, which muscle can elevate? This is question number 1. For example, in abduction, which muscle can elevate the globe? Is it the superior rectus or inferior oblique? And also in adduction.
Inferior oblique elevates in abduction, and yeah.
No, it is the reverse. In cases of abduction, and specifically abduction by 23 degrees, the superior rectus will be the main elevator. And in cases of adduction, and especially adduction of 51 degrees, the inferior oblique will be the main elevator. Okay, which is the main depressor here? The depressors will be the same. Okay, for abduction, the main depressor will be the inferior rectus, and for adduction, it will be the superior oblique. Okay, this is rule number 4. Rule number 5, which is regarding the tertiary action. Actually, these muscles, the vertical muscles, have 3 actions, not just 2. The most important one is the primary action. The second is the secondary action, and the less significant one, which just aid the horizontal muscles, is the tertiary action. Okay, and here it is ob-ab. So in obliques, they are abductors. They work with the lateral rectus muscle, and the reverse is true. The recti will work with the medial rectus muscles. Again, okay, I have 5 rules, but before these 5 rules, I want you to remember again this one, because you didn't mention this while I'm talking about the rule number 4, which is the main elevator and depressor. Okay, let's talk about the recti muscles. Okay, look here. This is lateral, this is medial. Okay, this is the blue one is the optical axis, and the red one is the axis of the muscle. In order to make them parallel, in order to get elevation or depression, how can you get this? By rotating the globe medially or laterally? Laterally. So here, the main elevator in abduction will be a rectus muscle, okay? Will be the superior rectus muscle. The reverse is true for the oblique one. Here, look at the oblique one. Here, this is medial, this is lateral. In order to be parallel, you have to move the globe medially or laterally? Medially. So here, the main elevator in adduction is what?
Superior oblique.
Inferior oblique. Okay.
Inferior oblique. So, elevator, yes?
Yes, elevator.
Yes.
Elevator, okay. Inferior oblique, depressor will be superior oblique. Okay, so this is rule number 4. You understand right now rule number 4. Rule number 4, which is the main elevator, which is the main depressor in abduction and in adduction. The elevator or depressor in abduction will be recti muscles, and the elevator and depressor oblique ones.
Oblique muscles.
Okay.
Okay.
Again, the rules here. Rule number 1. I want you to memorize these rules because these rules will be easier for you in the exam. Okay. Instead of just memorizing the primary, the secondary, and the tertiary action, here this will be very easy to be remembered. Rule number 1 regarding the recti muscles, which is the primary action?
Elevation and depression.
Elevation or depression, yes. Which is the secondary action?
Extortion and
Extortion, insertion.
Insertion, extortion, yes. This is rule number 1. Rule number 2, regarding the obliques, this will be the reverse. So the primary action will be insertion or extortion. Okay, and the secondary action will be
elevation and depression.
Again, yes. Rule number 3, which is all superiors are intorters.
Intorsion,
okay?
Yes.
And all inferiors are
extortion.
Rule number 4, which is main elevator, which is main depressor. Here the elevators like that, and here this is the depressors. In cases of abduction, if the eye is abducted, in cases of abduction, the elevator
superior rectus.
Yes, superior rectus, and here the depressor will be inferior rectus, the same. In cases of adduction, because
inferior oblique.
Yes, in adduction, the obliques will be parallel. Yes, here you have inferior oblique and superior oblique. Okay, yeah. Rule number 5. Rule number 5, which is regarding the tertiary action, which has no significant value. The tertiary action will be for all of the extraocular muscles.
Sorry, I could not really understand the rule number 5. Can you say it again? Which
Okay.
reaction?
I'll repeat this. The tertiary
Okay.
action is an action which helps the horizontal muscles. Actually, it has no relation or direct relation to the vertical muscles. But these vertical muscles like superior rectus, superior oblique, inferior rectus, inferior oblique will act by helping the medial rectus and the lateral rectus. Okay, so the recti ones will help the medial rectus, the oblique ones will help the lateral rectus. And here there is ob-ab. So the oblique will be abductors as a tertiary action. Ob-ab. Remember this one. Ob-ab. The first will be true. The recti will help the medial rectus. So the recti are adductors as a tertiary action. Okay, these
So
are the
what's
rules.
this action is called? I can't see
Tertiary.
clearly.
Tertiary. Yes, tertiary. It is from
Tertiary.
primary from 1.
Tertiary.
Yes.
Secondary, tertiary.
Secondary from 2 and tertiary from 3.
Okay.
مورد لا مثل تو
مثلا.
Okay. So these are the rules. You can write down these rules. Okay, these are the rules for the
and
action.
then on the wall, memorize desk.
Yes, you can. Yes, you can
on the wall.
This one. I think my handwriting isn't that obvious here. But actually, I can send you a photo. Some of the Arab colleagues wrote it down after yesterday's session, and I can.
Yeah, it will be nice.
Yes, I can send you just a photo. Okay, these are the actions of the extraocular muscles.
Yeah.
Regarding the relations, I have no significant. It has no significant importance. But I want you to remember something regarding the relation, which is the most important one. All the oblique muscles are below that of the recti muscles. Okay, so here in the superior rectus muscle, for example, here you have also superior oblique, but the superior oblique will be inferior to the superior rectus. Okay, and also again here for the inferior oblique, will be inferior to the inferior rectus. Yes. So I'll make the oblique in blue. Okay, this is inferior oblique muscle. This is superior oblique muscle. What do you notice? I notice that the obliques are always inferior to the recti ones. Okay, here in the superior rectus muscle, which is above this muscle? Which muscle is above? It is the levator palpebrae superioris will be above this muscle. This is the most important thing to be memorized and remembered regarding the relations. When you read the relations from my notes, you will find that it is imaginable. So here it is logic, and actually I don't find, or I didn't find, an MCQ questions regarding this one a lot. Okay, but I want you to remember that all the obliques are inferior to the rectus. Okay. What are the characteristic findings or characteristic changes or characteristic characters, unique characters regarding the extraocular muscles? At first, I have the nerve supply to the extraocular muscles. What do you think of the nerve supply or the nerve content of the extraocular muscle? Is it abundant or is it less abundant? It will be very abundant.
Yeah.
Okay, because in the eye you have to have very good coordination. You are looking elsewhere every day. Okay, you are looking every moment, so you have to have a very good coordination. Look at this one. The number of nerve fibers per muscle fibers will be 1 to 3 or 1 to 5 at most in cases of extraocular muscles. What about other extraocular muscles, or sorry, other skeletal muscles? It will be 1 per 15 or 1 per 125. Okay, so here you have more nerves, you have more nerve fibers per muscle fibers. So the ratio between the nerve fibers and muscle fibers will be higher in cases of extraocular muscle than any skeletal muscles. So you have more nerves in the extraocular muscles. This is important. What about the blood supply? Also, you have more blood supply in the extraocular muscles than in other parts. Okay, that's why when you are looking at the extraocular muscles, you will find a very thin sheath here. Well, imagine that this is the sheath, or it is called epimysium. Epimysium means the sheath of the muscle. Okay, and again, you will find that you have a muscle here. What about the connective tissue? The connective tissue will be larger here. Because of what? Because this connective tissue will carry nerves and vessels. And you know that these muscles are abundant in nerves and vessels. Okay, so here the connective tissue will be more abundant here like that. So you have here very large connective tissue. You have very thin sheath like that. So the epimysium will be very thin, which is the connective tissue sheath. And the perimysium, which is the muscle, sorry, the connective tissue between the muscle fibers, which will contain the blood vessels and the nerves, will be more abundant. So you have more perimysium and you have less epimysium. Okay. This is number one. Number two, if you are talking about the biceps, for example, you will find that the large fibers will be peripheral in the muscle here, and the small fibers will be central like that. Okay, so this is the orientation of the biceps muscle. So you have the largest peripheral, you have the smallest central. Unlike that of the extraocular muscles. In extraocular muscles, you have the smallest, which is peripheral, and the largest will be central like that. So this is the orientation of the extraocular muscles. Also, you have very abundant muscle spindle, which can be 1 millimeter long. What is the value of muscle spindle? It is responsible for proprioception and deep sensation. So when you are closing your eyes, and I told you to look while you are closing your eyes, look at the right gaze. While you are closing your eyes. You will notice and you will realize that you are looking to the right. Although you see nothing, but you will realize that you are looking to the right. This is called the deep sensation or the proprioception. This is a function of the muscle spindle, which is very evident here in the extraocular muscles. Also,
I didn't know that before.
Excuse me?
I just realized it. I didn't know it before, that we're looking right.
Yes, you didn't realize this before, but actually this is very important, because if you are looking, if you are closing your eyes, it will be very easy for you to be disoriented if you don't have this place sensation, or this position sensation, or this deep sensation or proprioception. This is extremely important in order not to get disoriented.
Okay.
So this is called deep sensation, and this is a function of the muscle spindle, which is Golgi tendon, which is extremely abundant and present here in the extraocular muscles. Also, you can see that if you do EMG, myography, here, if you do EMG, you will find some changes. These changes, if you see these changes in skeletal muscles, you can give the diagnosis of myopathy. But these changes may be normal or of normal variant in cases of extraocular muscles. So in extraocular muscles, you'll find some abnormalities. These abnormalities are not just abnormalities. They may be normal, okay? So they are normal findings in extraocular muscles. Then in skeletal muscles, in which you will diagnose it as myopathy. Also, for the extraocular muscles, I have unique fibers, which is what? I have two types of fibers, twitch type or fast fibers, and they have the strip-like structure, okay? So they are plate-like. plate-like. So they are called on plaque. They are responsible for something we call saccadic movement. I'll illustrate all of these. I'll explain all of these. And I have another one, which is a slow one, not twitch. It is a slow, okay? And this slow one is called tonic or slow. And they are grape-like, okay? The nerve ending here will be grape-like. So they are called on grape. Grape-like will be like that, okay? Like grapes. Okay, and this is called plate-like. It will be on plaque like that. They are responsible for pursuit movement or pursuit movement. What is the what do you mean by pursuit movement and saccadic movement? If I want to test the extraocular motility, and I told you to look at my finger, Dr. Tina, for example, look at my finger, and I'll move my finger right and left. Okay, so you will follow my finger. This following movement is called pursuit movement or pursuit movement, and actually this will be slow. Okay, so the pursuit movement is slow and it can follow a moving target. Okay, this is called a pursuit movement.
Perfect, yeah.
When you are looking or examining a patient with a slit lamp, and you are telling the patient to look right. For example, Mary, look at right gaze. Look at the right gaze. So Mary will look by what? She will look by saccadic movement. Yes. Okay, so this is called saccadic movement. So you use the pursuit movement in your examination, and also you use the saccadic movement again with your or in your examination. So you use both of them, pursuit movement and saccadic movement. Actually, the shape of the fibers will be in the pursuit movement. It will be grape-like, and for the saccadic movement,
plate-like.
Yes, plate-like. Actually, the type of fibers will be here. For the slow one will be, B and C, and for the, A and B, and here for the first one, it will be C fibers. Okay, this is not that important, but it was mentioned in the MCQs. These are the unique characters regarding the extraocular muscles, or the differences between the extraocular muscles and muscles from other areas, okay, or muscles, other skeletal muscles. Okay, right now, here, do you have any questions here in the extraocular muscles?
I have one question.
Yes.
Here is it's written that small fibers are around the periphery of the muscle and larger fibers are in the center. You said it differently. Yes.
I said so, actually.
Oh,
I said
really?
that. Yes, I said that the biceps muscle, which is here skeletal one, and extraocular muscles, which is different from biceps. In biceps, I said that the larger will be in the periphery.
Oh, yeah, okay. So you...
Okay, like that. And I said in the extraocular muscle, remember my illustration.
Okay.
I did it like that. Okay. So here, remember,
so it's
this
about extraocular muscle.
Extraocular muscles, and this one is biceps or other skeletal muscles.
Okay, thank you.
Not at all. Okay, here in this one, the slow or tonic type fibers, this one is unique for the extraocular muscles, but this first one is present elsewhere in the extraocular, in the skeletal muscles. But this one, the slow one or tonic one, this is unique for the extraocular muscles. Okay, is it easy?
Yes.
I want to mention something else which is written here in American Academy. Which muscle has the largest tendon?
Largest tendon? It's a superior oblique.
Yes, superior oblique.
Oblique.
Half of the muscle is a tendon. Okay, the tendon is 20 millimeter long and the muscle is 40 millimeter long. So half of the muscle is a tendon. Which muscle is the largest one or the longest?
Longest.
Lateral.
No.
Superior
Rectus.
rectus.
No.
Superior rectus, yes. Superior rectus
Yeah.
is the longest one. Which one is the largest one?
Superior.
Or the
Medial
thickest?
rectus.
Yes, the medial rectus is the thickest one. Okay.
Which
Medial
was the
rectus
longest one?
longest is superior rectus. Look at here.
Okay.
Superior rectus will be 41.8 millimeter long. So this is the longest one. Which muscle has the shortest tendon?
Medial rectus. I don't know.
No. The inferior oblique
Right.
one. The inferior oblique almost has no tendon. Or the tendon will be just 1 millimeter. So this muscle has no tendon. It will insert like a fan here in a fan-like configuration here like that in the inferior posterolateral quadrant of the globe. Okay, so almost this muscle has no tendon.
Okay.
Okay, so let's go to the MCQs.
Okay.
Do you have any other question before I go to the MCQs?
No, I don't.
No.
Okay, which is the largest extraocular muscle? Here, this must be specified. Largest or thickest is the medial rectus, but longest is the superior rectus. So this one must be specified. Either is longest or it is the thickest.
I think this means
So what's the
thickest
answer?
here.
Yes, so here you will
Medial
go with
rectus.
yes. Which one of the following muscle is supplied by the contralateral oculomotor nucleus? This one will be mentioned in neuro anatomy, but this is superior rectus. Superior rectus.
Superior rectus.
Yes, the superior rectus will be supplied by the contralateral oculomotor nucleus. Which statement is false regarding the inferior rectus muscle? It is innervated from its superior surface. True or false?
Yes. Yes.
This is absolutely true. Number 2 or B, it is inserted 6.5 millimeter, not centimeter, behind the limbus. True or false?
Yes, true.
This is true. Number C, it is the main depressor of the globe when the eyes adducted.
Don't know yet.
It's false.
I need to learn it.
False. No, this is easy. The recti.
No, it's not.
No. I told you the rule number 4. The recti will work by elevation or depression, but in abduction. Abduction 23 degrees actually. Okay, and the obliques will work in adduction. Adduction 51 degrees, if you remember.
So it is false.
Yes, because adducted is oblique muscles.
Here, yes. Okay, number D also is false. It lies inferior to the inferior oblique. What do you think? I told you that the obliques are always
more inferior.
Yes. So this one is also false. So this is false and this is false. Which one is false? Number C and number D. Actually, these questions, I told you, these are questions from IDOCS. So there are some errors or some wrong statements or wrong answers there. So number C and number D, both of them are false. Question number 4, the following extraocular muscles are correctly paired as yoke muscles. This one is will be mentioned in physiology, but what do you mean by yoke muscles? Yoke muscles are muscles that are working together in the same direction. So for example, if you have here, if you want to look to the left, the patient is looking to his left like that. So I have here to contract the lateral rectus of the left eye and the medial rectus of the right eye. So the direction will be the same like that. So here, these are called yoke muscles or yoke muscles. Yoke muscles are here in this example, the medial rectus of the right eye and the lateral rectus of the left eye. Again, another example here.
Is the answer.
Okay, another example here. If you are looking to the left and upward here.
Mhm.
To the left and upward. What is the main elevator here? Here, elevation and adduction. What is the main elevator here?
In which one?
For-
So
for the right
in
eye?
one eye, in the right eye,
Yes.
we have abduction, we have adduction and elevation. Yes. Oh my God.
So it will be
Adduction,
inferior oblique.
Inferior oblique.
So superior oblique, inferior oblique.
Inferior oblique.
Yeah.
Okay. For the left eye, you will have
And
the
here
superior.
abduction, superior rectus.
Yes, superior rectus. So they are yoked muscles. If you are looking here in this direction and this direction, you will have to contract the right inferior oblique and the left superior rectus. Okay. Another example, which is here, if you are looking here and here like that. So you are looking downward and to the right. Okay. For the right eye,
Abduction. Yeah.
yes, for the
We
right eye,
have
and
main
for the left eye.
abductors.
For the
For the-
left one, it's superior oblique.
Yes, left one is superior oblique and right one
Inferior
Right one is
rectus.
rectus.
inferior
Yeah,
rectus.
inferior
I
rectus.
think this became easy for you to.
Yeah,
Yes.
a little bit.
Okay, so these are called yoked muscles because they share the common direction. They are
Yes.
working
Mhm.
together in the same direction. So here, this is a physiology one, but let's
Try.
let's answer this one. All of these are yoked except right superior oblique and left inferior rectus. What do you think? Is it yoked or not?
Superior oblique and inferior, yes.
Yeah,
Yes,
it's
they are
yoked.
yoked muscles. Okay.
Yeah.
Right medial rectus and left lateral rectus.
Yes. They
Yes.
So, yeah, yeah.
Okay. Right superior rectus and left inferior oblique.
No.
No.
Yes.
Yes, they
Yes.
are.
Okay. Yes. If you
Ah.
are doubting something like
So
that.
this rectus, the D is wrong. Inferior rectus and superior rectus, they are not.
Yes.
Ah,
They
yes.
are not yoked muscles. So number D is
If they
absolutely
contract together, it will be very interesting view.
Yes. Yes. Okay. So. Okay, but here look, if you are suspecting something, you have to, if you suspect something, you have to illustrate this. So number C, you said that it is no, but after a short of time, you after a very short time, you said that it is true. You are suspecting this one, so I have to illustrate this. The right eye, I have what? I have elevation in abduction because I have right superior rectus here in this one. So this will result in this one. And for the left eye, I'll have what? I'll have this one, which is elevation in adduction, left inferior oblique. Okay, so both eyes will look to the right and upward here. So they have the same direction. They are working together, so they are yoked. So number C is true, and number D is absolutely false. Question numbers 5 and 6 regarding levator palpebrae superioris. All the questions here regarding levator will be mentioned after we explain the levator palpebrae superioris as a layer of the eyelid. Okay, so this will be postponed. Which statement is false about the extraocular muscles? The C fibers are required for tonic contractions.
Yeah, okay. C
Yes.
tonic, yes, okay.
Yes. Yeah, C for tonic, actually A for twitch or fast fibers, and B and C are for slow or tonic contractions. I'm not sure if I mentioned this like that or not, but C are responsible for tonic. Also B for tonic or smooth pursue or smooth slow movement, and also A here it will be responsible for twitch or fast fast movement, which are responsible for saccadic movement. So A and B and D, they are true. Number C, extraocular muscles contains large numbers of specialized sensory and proprioceptive nerve endings, such as muscle spindles and Golgi tendon organs. What do you think of this one? Yes,
Yes.
this is absolutely true for proprioception. Number E, extraocular muscles is less vascular than skeletal muscles. What do you think of this one?
Oh, it says wrong. False.
This is absolutely false. Yes. Which extraocular muscle is inserted nearest to the cornea? This is very easy.
Medial rectus.
Medial rectus by 5.5 millimeter distance from the lip. Question number 9. Which statement regarding the levator palpebris superioris is false? I'll mention this levator again. Okay. Question number 10. Which of the following extraocular muscles can perform intorsion of the globe? Rule number 3 in our rules.
Yes.
Intorsion or
All
inferior.
superiors. All superiors are
Superiors,
intorsion.
yeah.
So number A, which is superior oblique, all superiors are intorters and all inferiors are extorters. Which is the only extraocular muscles not to originate at the orbital apex? This is very easy.
Inferior.
Inferior oblique. Okay. 12 regarding levator. 13. The superior oblique inserts on which quadrant of the globe? This is very easy.
Posterior superior.
Posterior superior.
Yes, posterior superior. So the answer is A. Number 14. The inferior oblique inserts on which quadrant of the globe?
Inferior.
Posterior lateral. No.
No,
So
posterior lateral.
Posterolateral, yes. So the answer is number B. Which rectus muscle receives only one ciliary artery? This was mentioned.
Lateral rectus.
Yes,
Lateral,
lateral rectus, but actually the lateral rectus will receive also other supply from the lacrimal artery, which is again a branch of the ophthalmic artery.
Yes, okay.
These are regarding the extraocular muscles, and here the questions of John Ferris, you have to solve them alone. Actually, I want you to remember and imagine the movement of the extraocular muscles. If you have any questions before I end this session, just tell me and I can repeat this.
No, I think these 5 rules are the most important.
Yes, for the exam.
Yes,
for the, actually, for the exam, you have to memorize the 5 rules in order to be quick in the. But actually, I want you to know beyond these 5 rules, because these 5 rules are not for explanation. They are just for memorizing. But before the 5 rules, I have explained why do I have the primary position, or sorry, the primary action of the recti will be such elevation or depression. Why? Because this is nearer to the primary position. Why do I have the obliques having intorsion and extorsion peripheral, or sorry, preferred over the elevation or depression? Because again, this is the primary position and this is nearer to the primary position. Why do I have elevation and abduction, elevation and abduction? These are all I want you to know the explanation behind this, because this will be very helpful for you in order to understand strabismus well.
Yes, okay.
Okay. Actually, after you do this, I want you to, if you have some time, to look for the strabismus review for me, or the strabismus videos for me. They are available on YouTube. These are just strabismus revision in 4 hours, if you have some time. Okay.
You have, there are your videos there?
Yes, I have YouTube videos for strabismus revision.
Okay.
I can send you the link. And actually, to be honest, they need concentration, because my rate was fast. Okay, because they are just revision, and I was revising American Academy. Okay. So it was a very bulky content for me to be revised.
Okay.
Okay, I'll end this session.